Say again.
Yeah.
Hello?
Yes.
Is the sound coming through?
Yes.
Great. Thank you. Sorry about that. Our apologies for that. It was a technical glitch with our camera. Greetings, everyone. My name is Tanusha Singh. I'm leading the NIOH Occupational Health Outbreak Response Team. Thank you for joining today's session on the implications of COVID-19 on the workplace. A very warm welcome to you all from the National Health Laboratory Services and the National Institute for Occupational Health. We are a division of the NHLS and a complementary division to the NICD, which many of you are familiar with. The NIOH has been conducting a series of training sessions from the early times of the outbreak, and we had been conducting it for various occupational groups as well as various industries. And we are very pleased to be conducting today's session for shop stewards and health and safety professionals in the main. All our sessions are recorded, and the recordings are available on our website. The website is 0 rated, so you can access this information, the presentations, the videos, fact sheets, and posters. I'm just going to read out in alphabetical order the service providers that have 0 rated the website. It is CellC, Internet Solutions, MTN, MWeb, Rain, Telcom, Vodacom, and Vox. The live streaming is unfortunately not 0 rated. However, today's session marks a very important milestone in our training delivery, in that we are able to make data accessible to the participants, and that is being administered through the Wits Health Consortium. And at this point, I'd like to acknowledge the Health and Welfare HWSETA and Wits Health Consortium for making funding available for us to conduct the training sessions and to make the data freely available for participants. Now, it is, as I said, the first time that we are conducting the training where data is being made available to participants. And so there naturally may be challenges in making the data accessible to you. So please bear with us as we iron out these glitches. We are envisaging that in the future, this will be smooth running and without any of the glitches. As we move to stage 3, as we ease out of the lockdown, it is important that employers are held accountable for employee well-being and safety. However, at the same time, the employees are empowered and understand the importance of some of the precautionary measures which are life-saving and they need to adhere to. And that is why we are very glad to be conducting today's session on the implications of COVID-19 for the workplace. Now, we are planning to host this session again on Friday, so that more participants can join who were not available to join today's session. So we're asking you to assist us.
Tanusha?
Yes?
Tanusha, can I ask you to hold on? I can see a lot of the participants are saying they can't hear. Can the IT guys, please?
Not a problem. So our IT guys are telling me that it's all fine. They tested it on our side. The sound is fine. It may be on their side. So they may have to unmute their mics. Can we just indicate on the chat that participants unmute their mics?
The speakers.
The speakers, yes.
On their devices.
Right. Okay, wonderful. We're seeing that the sound is coming through now. Thank you, Saggy.
Pleasure.
Okay, so we will be running the session on Friday again, so that it is available to other participants. So again, as I said, please assist us in spreading the word and the invite to colleagues in your networks. With that, I'd like to thank you again for joining the session, and I'm going to hand over to our program director, who will take you through some of the house rules and also the program for today. Over to you, Mr. Ashraf Lakeby.
Thank you very much. That was the Dr. Tanusha Singh, who's also the head of our immunology and microbiology section here at the National Institute for Occupational Health. So before I introduce Segi Pillay of the Wits Health Consortium to give you a formal welcome as well, I want to just give you an orientation. For those of you who've joined a Zoom type session for the first time, it is important for you to note that on your screen at the bottom, you will have a chat box bubble. And that chat box bubble is for any comments that you want to make. Like, for example, the sound is not on, you can't see the slides and so on. Then you have a Q&A bubble on the other side of that. I hope I'm pointing on the right side. In the Q&A section, you have to type the questions you have for the presenters that's on the program. And so you would have received this program, and on the program, as you'll notice, there's the branding of the Health and Welfare HWSETA and the Wits Health Consortium as well at the top. The sequence of presenters are there, and when they do their presentations, please use the Q&A bubble at the bottom to type your questions. And we will endeavor during the course of the session to ensure that we get to most of your questions. Questions that are not covered during the session is dealt with by presenters and added to our frequently asked questions on our website, as well as if you have any follow-up questions, I'm going to encourage you to please email us at info@nioh.ac.za. That is info@nioh.ac.za. So that's just orientating you. That at the point when presenters are giving their presentations, you will see the slides cover the full screen. And that means any questions you have for them, you type at the bottom in the Q&A box. So, we are not unable to handle hands at this point in time. I see Knox Bananas asking about raising hands. When we have the Q&A at the end, it will be based on the questions that you've typed in the Q&A box. For the size and numbers of the session, it is not viable for us to have all of your microphones unmuted, and therefore you need to type your questions at the bottom. I now have the pleasure for this joint collaboration between the NIOH and the Wits Health Consortium, supported by the Health and Welfare HWSETA, to ask the representative of the Wits Health Consortium to join us for the introduction, and that's Segi Pillay. Segi, are you online?
I am online, Ashraf. Thank you very much.
Okay. So if you wish your video to be projected, we can arrange that. Or if you just want to be an audio, that's also fine.
You can get the video going if I'm blocked out at the moment.
Thank you. One moment, and then that will be sorted. Is it the remove? I don't know how to know. No, not the remove.
You want to talk now?
Yes, for his video.
Yeah.
And you?
I'm going to make him a co-host.
Yes.
Tell him to open video for the second.
You can open the video on your side, Segi.
All right. Okay. There we are.
Correct. So we now need your screen.
Okay. Cool. Thank you very much, colleagues. Ashraf, thank you very much for that introduction, and thanks to Dr. Tanusha Singh for her comments. Just a very quick high-level sort of overview. I see at the moment there are over 213 people on the webinar. This is really, I think, a fantastic start to the program. The future sessions, we want to use the bulk of the time just for the training, but just as this being the first one that's being run for all of you, I thought perhaps some background for the participants will be important. And the background is important because we also want to get the message out to your colleagues and to others that these webinars and these sessions are going to be run repeatedly, various components related to COVID, over the next 3 months. And we are really privileged to have received funding from the Health and Welfare HWSETA to fund these sessions, including to provide data for individuals who have difficulty with not having data themselves. So that's being provided as well. Now, we're really pleased to have an institution of the standing of NIOH who's delivering these programs. NIOH, which is part of the National Health Laboratory Service, is also driving the testing part of the COVID program and have been doing some phenomenal work. But this particular training program itself is really to start preparing the workplace in return for the over 8 million workers that would be getting back to work from Monday next week. Obviously, large numbers of us are already probably back at work, but the next big wave is going to be for next week. And we got to do all that we possibly can to manage this pandemic and to flatten the curve, as everyone's referring to it. So the training programs are being developed in various modules by the National Institute. It's being funded by the Health and Welfare HWSETA. And getting this information out, I think, to all of us, especially to shop stewards in this particular case. You know, you're playing very important roles at the workplace, interacting with management as well. So we got to take co-responsibility to ensure that the workplace is safe, that all the minimum precautions are in place, and that we have all the necessary monitoring and evaluation mechanisms so that workers and patients and others who visit the workplace are properly protected, and that we can get back to as normal a life as possible over the next couple of months. So we're delighted that we can provide these training programs. We accept that today's session may not be ideal. It is the first session, but NIOH is a very experienced organization. They have run these programs repeatedly in the past. But we will improve the program as it evolves over the next 3 months. And we hope that you will engage with us as well to make suggestions on how we can get this better, how we can ensure that the content is more responsive to your requirements, and that we can all ensure that these programs meet the standards that we normally accustomed to. The program will be recorded. It'll be available in the portal that NIOH has already talked to, so you can always go back and visit, and we'll create the mechanisms for you to engage with the experts and continue to update your knowledge as we go on over the next few weeks. I can see someone is saying my curtain needs to be drawn. Does that make me look a little better? Unfortunately, I got my COVID beard on, so I apologize for that. But thank you all for participating. I hope that you will engage with us as the program unfolds. But most importantly, can we get this message across to as many of our colleagues as possible so that they can participate in the appropriate sessions as the program unfolds over the next coming weeks. Tanusha and Ashraf, thank you very much for this opportunity. We had hoped that labor, that's HWSETA, DENOSA, PSA, and NIHAO would have participated in this session. Unfortunately, it was too short notice, and I'm sure the next session will get someone from labor as well to just talk and give a few introductory remarks. Thank you very much for this opportunity, and I hope that you will enjoy and find this session valuable from the workplace perspective. Thanks, Ashraf.
It's a pleasure. Thank you very much, Segi Pillay, on behalf of the Wits Health Consortium, a partnership in this particular series of sessions that will continue over the next few months. And we want to welcome all of you as participants. Some of you, unfortunately, as Segi has mentioned, your representative organizations that were part of the planning and also part of identifying your contact details for those who can access the internet and therefore the Zoom session, and for the invite to reach you. And the invite has gone broader as well in order to ensure that we secure the sufficient numbers. So we thank also those organizations, as Segi has mentioned, who's contributed to arranging all of this. So back to the program. We have had the welcome from Dr. Tanusha Singh, and we've had the introduction by Segi Pillai on behalf of the Wits Health Consortium. Our next series of items on the program is firstly by Dr. Mpumi Ndaba from our occupational medicine section. That's the COVID-19 in the workplace preparedness section, and then it's followed by a guest presenter from the Department of Employment and Labour, Warren Mullen, who's going to speak about the required precautionary measures for COVID-19 in the workplace. And the last part of the three key components is the screening procedures and follow-up. So when people arrive at work from either lockdown or any other quarantine or working from home back at the workplace, what are the screening procedures required? And that will be dealt with by Dr. Odette Volming. At the end, we hope to be sticking to our time so that we can have a Q&A session at the end. And I now hand over to Dr. Mpumi Ndaba. Okay, so whilst we just pausing for a moment just to sort out our clicker, it's important for you to focus on what the presentations deal with, especially in the light of your roles and responsibilities in the workplace, either in your capacity as shop stewards or in your capacity as health and safety representatives with all the structures that are in place to the workplace. Thank you, Mpumi.
Good morning, colleagues. My name is Mpumi. I'm an occupational medicine specialist from the NIOH. I'm going to be briefly going through the workplace preparedness for the COVID-19. And just a little bit of background, NIOH is part of NHLS, NHLS being the largest diagnostic pathology service in South Africa. We provide lab and related public health services to more than 80% of the population. We support both national and provincial health departments. And we've got about more than 7,000 employees and 356 laboratories. And other than the laboratories, there's also NIOH and NICD. Some of the functions of the NIOH include we provide specialized services, but mainly we look at promoting decent work through cutting-edge research, service delivery and training. We do quite substantial bit of teaching and training, knowledge generation, advisory services. We're also part of outbreak responses, and in total, all of these are encompassed within an occupational health framework. So,
okay, we're just going to get the slides to project in its progression.
Thank you. So while we go through this presentation, some of the source, some of what we're going to be mentioning is sourced from some of these reputable websites, the NHLS website, NIOH, and NICD, as well as National Department of Health, but internationally the WHO website and some of the reports from the CDC website. So as a way of background, currently we're sitting at just above 5 million infections globally, and there have been about 347,922 deaths as at yesterday in the evening. And coming closer home, looking at the South African perspective, in South Africa we've had just more than 23,000 confirmed cases, of which more than 11,000 have recovered, and we've had about 481 deaths. And the province that is leading currently with statistics being the Western Cape. However, there is no evidence that there's any province that is not affected at this stage. And still on the South African perspective, we know there was a lockdown in March, on the 20th of March, and the lockdown was uplifted on the 30th of April. We progressed from level 3, currently on level 4, approaching, so we progressed from level 5, we're currently on 4, we're moving towards level 3, hopefully by beginning of June. What we know currently is that there have been, initially the cases were travel acquired, but now we know that there's a lot of community spread as well. And of particular importance is that of these, in terms of the community or the workplace transmissions, we have quite a few occupational cases which currently are health workers. And some of the workplaces that have been involved, based on the reports, have been initially travel-related. There were teachers at the very beginning of the epidemic, the health workers, retail workers, we've heard of correctional services and mining. But throughout the epidemic, while there've been different workplaces as they open and close, health workers have remained, the prevalent occupation that has been affected. A little bit of microbiology. Coronaviruses, this coronavirus, it's a group, it's a family of viruses that are responsible for common cold, but they usually cause self-limited upper respiratory tract infection. So you will have known from reports that it's referred to as a novel coronavirus. Novel meaning it's new, it's unknown, and hence it means we don't have immunity. It's not like any other flu that we normally have, and then your body manages to fight that off. So as a way of transmission, what is very important for us to remember is that transmission of this virus is through direct contact, where you touch an ill person or a contaminated surface, and also through droplet transmission, where you inhale those droplets again. And the issue of 1 to 2 meters, remember, it talks to what we've been talking about with regards to social distancing, because as you sneeze or you cough, droplets are generated of different sizes, and then the larger droplets, because of gravity, they fall to the ground within a 1 to 2 meter radius of the person within a few seconds. But then smaller droplets, and also depending on the speed that propels the droplet, they might even go further. So this virus is more infectious when the person is symptomatic. So what are the symptoms that we could look for? There's a number of symptoms that have been mentioned, but some of the common ones include a fever and a cough, shortness of breath or chest tightness, a sore throat. And at an earlier phase, there was also mention of upper respiratory, more like, the rhinitis, but currently it doesn't seem to be a prominent feature. We are mentioning these because there might be other presentations, but for the workplace, it's very important that we look around some of the symptoms, the acute respiratory illness of like sudden onset, which has one of those. And these are the same criteria that are used for screening in the hospital setting and also in workplaces. So as we've mentioned, the symptoms, what is important also for the workplace is that 80% of the people who have disease will have mild disease, which is almost like a common cold or flu. And if you think of currently, this is the time for the common cold or flu. This is why it's very important that at this time we think of, the coronavirus. And this is the reason why in most hospitals or healthcare institutions, we actively look for these symptoms. And 15% of the people who get this disease, they will require hospitalization. And 5% of the cases become critically ill, requiring ICU. But of most important is to remember that persons with underlying comorbid illnesses, especially pulmonary disease, the elderly, the immunocompromised for any reason, are at more risk of acquiring or having the worst clinical outcome. So a little bit on the terminology, I thought it's important for us to go back and remind ourselves what is quarantine and what is isolation. So when somebody is asymptomatic, let's say maybe you're in contact with somebody, but you're asymptomatic, you don't have any symptoms basically, then we call that, then you need to quarantine yourself for the period longer than the incubation period, which we mentioned that the incubation period is about 2 to 14 days. You need to quarantine. What you do during quarantine is actually waiting or monitoring yourself to check if you have symptoms, if you will have symptoms or not. But at quarantine level, it's important to know that people who go on quarantine, it's not anyone who has had a confirmed test. And then isolation then is a separation of a symptomatic or an ill person to ensure that the disease is not transmitted. There's currently no treatment, and the vaccine, as you know, we still don't have the vaccine for SARS-CoV-2. But then how it's managed currently is through early supportive therapy and monitoring. Very important also for our workplaces to remember how long this virus persists on different surfaces. So this is a virus that has a very fragile outer membrane. and it's not very stable in different environments, can be killed by simple disinfectant, which is why we always...
Hi, Dr. Ndaba. Dr. Ndaba.
Yes.
Hi, sorry, my apologies, it's Peggy. I see a couple of people saying you're talking a little too fast. You want to slow down a bit?
Okay. Thank you. Okay. So when we're talking about the virus itself, the outer membrane is very fragile, which means it breaks easily, and it's not stable in the environment and can be killed by simple disinfectant. So we know from various studies that have been done that survival time in the environment, how long it survives in the environment, depends on the pH. Remember, the pH is the acidity or how soapy alkalinity the surface might be. The inoculum size, for example, how much, let's say as you're coughing out, how much the droplet is or how much the fine particle is, the dryness of the surface where it lands, the temperature, and then exposure to disinfectants, as I said. So what we know as well is that common disinfectants, such as those that have 70% of ethanol and bleach, can kill the virus. So at the bottom of the slide, I've got an example of different materials which show the duration of how long, the lifespan of the virus on these surfaces. If we start right above, there's aluminum. So if you have an aluminum surface, the virus, if not cleaned, it might last there for 2 to 8 hours. We move on to the next. If it's steel, it might be 48 hours. Wooden material, 4 days. Paper, 4 to 5 days. Glass, 4 days. Plastic, 5 days. And surgical gloves might be 8 hours. So colleagues, we will recall as we're going through this, that now this should start to talk to our surfaces that we have in the different workplaces, hospitals that we are in. And this is going to be talking to how often are we going to be cleaning these surfaces, because this survival time, as I said, it talks to how long the virus will last. If the virus was to land on this surface and this surface will not be cleaned for a period of time. So when we come to the workplace, we know that we might have people who are in the workplace who might have acquired this disease or the condition through a community, acquisition, or they might be acquired through the workplace. So as we said, if we're in the hospital or healthcare setting, the workplace might include also occupational cases. So as people return to work in different workplaces, I know in hospitals a lot of people didn't close. Remember, some people will be returning to work following a lockdown. These are people in offices, and some people have been in isolation, also in lockdown, but also other people have been in quarantine. They come back to work, even in our healthcare settings. But then there's also another group of people who, for some reason, they might have been on leave or sick leave or maternity leave. These are all people who are coming into the workplace. So why are we talking about this? Why should we worry as employees in the workplace? Because all of us now, as we get to the workplace, there's risk of exposure. We don't know if we're going to be exposed at home or in the workplace, but because there's so many of us in the workplace, there's a risk of getting the infection. So we might acquire the infection, but also remember, if I don't know my status, or if I don't know whether I've got the condition or not, or if I'm asymptomatic, and within the period that I can transmit, I might be transmitting to somebody else. There's also the issue of financial risk, the use of medical aid, sick leave, if you already have sick leave that is exhausted, and all other finances that might go with it. So also people who have no medical aid cover, it means they will have to go and use an already overburdened public health service, and we think of the queues and all of that. So these are all the factors that affect the workplace, because if you have to join the queue in the public health facility, it's not as easy as just going for 15 minutes and come back. So it's going to affect number of people in the workplace. A bigger risk as well is asymptomatic workers, because as we said, they might transmit to others because we all don't know who has or who does not. The mental health aspect as well, because we are not the same. People come back to the workplace. Now there's also a lot of psychological, there's anxiety. Does it mean coming back to the workplace as I'm at more risk of having, of acquiring the infection? But also the other bigger issue is people with already psychiatric conditions. the conditions might seem to be exacerbated more because there are a whole lot of other issues, especially around the lockdown, but also anxiety around contracting this from workplaces. And then the bigger issue, again, is also returning to work or disability. People who've had infection, with this COVID virus, and maybe they're impaired, they've been to ICUs. These people might need to be rehabilitated and accommodated into the workplace to be able and assess if they can still do the same duties as they did before. So we know that there are some workers who have been, as I said before, who've been labeled as these are workers at risk of infection. But before I go to the specific categories, I want to emphasize that every person may be at risk of exposure to the COVID-19 virus, to the SARS-CoV-2 virus. But then the risk is higher for workers who are interacting with persons that may be potentially infected. But then we know as well that there is no way that you can see that someone is infected or not. So it means all of us who are interacting with people are at risk as well. More so if we're interacting with people from our work that we do. Immunocompromised workers are at higher risk as well because of the pre-existing conditions. Remember I mentioned before. So some of these conditions include people with asthma. Is it controlled? Is it not controlled? Diabetes, heart disease, cancer, kidney failure, and a whole lot of other diseases. But while I'm on this slide, I want us to remember that most of the information we have comes from the other countries, but particularly as South Africa, we know we have high prevalence of TB and HIV. So some of those might not have been mentioned in other preliminary reports that have come out, but we know that we do have a lot of immunocompromised workers or people who've had TB and HIV, which is going to talk to how we determine who is at risk and who is at not in the workplace. So some of the workers are also at increased risk of exposure. From an occupational perspective, some of the workers that work in airline operations and some of the workers in border control and healthcare facilities, it might be healthcare workers or health workers in, let's say, border control facilities or airline operations. It might be workers in laboratories, pathology and funeral services, solid waste and wastewater management, but also carers and teachers, because you find that sometimes you do have health workers who are in the workplace in the teaching or in the school facilities, as well as those who are in old age homes. But coming closer now to like general workplaces, other than occupational exposure, there are other categories that are also at increased risk of exposure. As I mentioned, these are people interacting with people, teaching staff, cleaners, security workers, transport people, canteen, maintenance staff, and visitors. So all these other occupations that interact with people. The list is not exhaustive because different workplaces have different people in it. So if we remember now, we go back to, if we've heard of the concept of risk assessment. So in a risk assessment, we look at the hazard, we try and identify the hazard, and then we look at the risk of what would happen to the person should they acquire the virus. So the hazard in this instance is the virus itself, and then the risk, what's the risk of you getting adverse effects from acquiring the hazard. So it is very important that we do a workplace-specific risk assessment. So if you're in a specific setting, you have to do a risk assessment for that setting, looking at what is the risk. We know currently our risk, the risk is all COVID-19 virus. Now we look at the different workplaces. Who is exposed? How many people are here? Who is exposed? And how often are they here? What activities do they really do? It's very important that we remember that a risk assessment cannot be a blanket document because different workers have different risk exposures based on specific jobs that they do. So you might have that it's a casualty, but you have 2 nurses working there, but it doesn't mean that their risk will necessarily be the same because of what we have discussed. While on the risk assessment, it's very important also that we remember to include all other hazards. So we look at the biological hazards, in this instance, the virus, the physical hazards, the chemical and economic hazards, as well as psychosocial hazards that I've alluded to. While we're on this, there's a lot of cleaning that you remember that is taking place. So in that instance, we should remember the hazard of the chemicals that we use in our different workplaces. So what are some of the ways that we have used generally in occupational health and safety to mitigate the risk in the workplace? So in the workplace, in general, we normally talk of primary prevention. This is now we prevent or minimize the risk of transmission in the workplace. We also have secondary prevention, where we're saying somebody has already acquired, but we need to identify those people at risk or those who already have the disease. And then there's also tertiary prevention, where somebody has had a condition. Now we are trying to rehabilitate them into the workplace. We're trying to prevent other people from acquiring from that. So the primary prevention mainly, if I may link it to the risk assessment that I spoke to, the risk assessment will also entail the controls in place. When we talk about controls, we talk about measures in the workplace that we use to minimize the risk from acquiring the hazard. So some of the controls include engineering controls. These are physical controls that are not depending on the person. For example, if you have to build a wall as a barrier and so forth. Administrative controls means these are administrative measures in the workplace. For example, if you don't want people to go to an area, then you sort of have a note that says people are not allowed to go through here, and PPE is also one of the controls. But I want to come back to the issue of engineering and administrative controls. It's not going to be covered in detail today, but just an orientation around those, that some of the controls might be engineering and some are administrative and some are through personal protective equipment. So as part of primary prevention, we also need to think of business continuity, pandemic preparedness and policies. And of utmost importance is education and training, as well as health promotion amongst in the workplace for all that are there in that workplace. So some of the workplace changes, for example, that are for consideration include engineering controls. So things like we review or improve ventilation in the workplace. We always recommend more the natural ventilation and more like mechanical ventilation where it's possible. But remembering that aircon is not necessarily a good means of ventilation unless we know whatever is sucked out, where does it go and so forth. So just seeing an air conditioner doesn't mean necessarily that there's good ventilation, because an air conditioner is merely circulating air and cooling it down. But it's very important that you know what kind of ventilation is in your workplace. There are also administrative control, which we're going to talk about, and also substitution, and as well as PPE. We are going to discuss this in detail maybe in the future session. Some of the administrative controls that have been recommended are social distancing. You will recall we spoke about the 1 to 2 meter distance from which, or within which somebody is likely to be infected if someone is sneezing or coughing, which is the basis for social distancing. And these need to look into more office space, and other people might need to work off-site so that we have fewer people around the workplace. We need to look at workplace facilities. So some of the facilities, you look at the bathrooms, you look at the kitchen, you look at the restrooms, some of these shared areas, because you might find that ordinarily this area is empty, but because it's tea room, people flock in there. And then also we need to look at the access control for staff, visitors, dedicated, streamlined and controlled access, so that at any stage we know who is within our facility, should we need to trace them again. It's very important to educate and inform people because, as I said, all of us are quite anxious around this time. So some of the information that needs to be shared in the workplace needs to include the facts about the disease, what I've alluded to. And then also people need to have an updated list of affected countries. In South Africa also, we also need to know which other provinces, to what extent and so forth. Latest policies regarding sick leave for our specific workplaces. How are our workplaces going to respond or adapt to this through sick leave and leave? What if somebody doesn't have sick leave, and what if somebody doesn't have leave anymore? And it's very important for our workplaces that people are not punished for staying away, even for flu, because as I mentioned, it's flu season, but also some of the symptoms for COVID-19 are almost the same as those ones of the flu. And also we should make it possible, feasible for our workers to work from home. If there are people who can work from home, let us encourage that. So some of the training and awareness, this should not only be limited to the usual training that we do, the posters in the workplace. We need to sensitize the skeleton staff. There are people who might be remaining back in the workplace of the changes that are going to be implemented. We need to communicate with staff at home. Now, people might be at home. When am I coming back? When you come back, this is what you'll find. Changes that are currently being implemented. We need to know who are the key operational people. HR and access control personnel, what are the changes that need to be implemented there? What should they do in different situations? We need to check if our procedures are in place and everyone knows what procedures to be followed should this incident or should this happen. And also some procedures that have been, yes, they have been working, but that was before COVID time. So we might need to look at those procedures and review them in line with COVID. And what's very important is to remember the issue of confidentiality versus the public health outbreak. Our workplaces need to ensure that while we know that we respect confidentiality, but in a public health outbreak, there has to be means of more people knowing. So it's always good that maybe there's a health worker or an occupational health service that could provide that service of the health worker being the area where people can disclose their conditions and so forth, because that is part of risk management. And very important, the issue of health promotion. You have your own condition. It's very important to know more how your condition can affect and how best to manage your condition. So these are some of the prevention practices that we need to keep on remembering in the workplace. People need to practice good hand hygiene, practice good respiratory hygiene, remember the issue of social distancing or physical distancing, and people need to stay at home if they are ill. Also, very important, the wiping down of all surfaces with disinfectant. I've alluded to this, the screening and identification of potentially affected employees, limit contact and movement. This is essential for our workplaces to start practicing, because remember, I said people come to the workplace from different directions. We don't know who has what, but ideally we don't want to bring somebody whom we know that is affected with COVID-19 to the workplace because of the risk of transmission. Social distancing is also important in our workplaces, in our different processes, but let's ensure that in our workplaces there are facilities and there are means to promote regular and thorough hand washing of employees, the contractors and customers. If it's not possible to have running water and soap, then we can should provide means for people to sanitize their hands, in place of washing. But obviously, washing cannot be replaced by sanitizing where the hands are obviously dirty. Respiratory hygiene should be practiced in workplaces, and people should be informed that they need to avoid touching their face, especially while at work. And we also need to insist, as I mentioned, the issue of staying away when people are sick. So what are some of the workplace preparedness measures that we need to start thinking about? What is the anticipated number of staff to be on duty on each day? So we need to have an idea how many people are supposed to be here, given the facilities that we have. So where the services were closed, for example, I know even some of the hospitals, maybe there's no visiting hour, or maybe there are no OPD clinics and so forth, and some facilities, some of the services have been closed up. Once you open up those services, now let's think about the employee public shared spaces. It means then there's going to be more people in that shared space. What is the risk to the worker? And let's also think of the risk assessment, because we might have done the risk assessment based on the few people in the workplace. Now let's prioritize what are the operations that happen in this area, activities, and of utmost importance, the shared spaces, as I mentioned. So some of the workplace practices that we need to start to review based on what I've spoken about. The mass gathering. Now, if you think of water, coffee station, the common areas, the restrooms, and then also waiting areas, the clinics, the medicals that are done in workplaces, the meetings, if we can try and consider doing meetings in an online manner, or if we do have a meeting, have fewer space in a bigger room so that we practice social distancing. And there are some of the specific procedures that are done in workplaces. So these are aerosol generating procedures, and also that we need to be looking into. Sometimes the breathalyzers in different workplaces as means of access control and so forth. But also public spaces are also other people's workplaces. that brings me to the end of the presentation. But before I hand over to my colleague, I'd like to inform or maybe bring it to people's attention that at the NIOH we have an email, info@nioh.ac.za, and as well as the hotline where we sort of particularly streamline it for workplace queries and assistance where we can. I thank you.
Could you just pause that slide? Thanks. Thank you very much. That was Dr. Mpumi, who is from our occupational medicine section at the National Institute for Occupational Health. I want you to take a screenshot of this slide, please, or take your cell phones and just take a quick peek of the slide. The slide and presentations, as some of you have asked, will be made available via the website. And if you remove the info at the beginning and just add the www.nih.ac.za, this is our zero-rated website. That's the contact details for support and more information. Thank you very much, Glenn, for that. Our next guest presenter is Warren Mullen from the Department of Employment and Labour. Warren is joining us and will be dealing with the aspect of the required precautionary measures for COVID-19 in the workplace. Thank you, Warren.
Thank you. Thank you, Ashraf, and thank you for the NIOH for allowing me this opportunity to present today. Yeah, good morning to every one of you that are attending. Yeah, as I was introduced, my name is Warren Madden. I'm from the Directorate of Occupational Health and Hygiene at the Department of Employment and Labour. So today I shall be talking about the required precautionary measures which are legislated in terms of the occupational health and
So, Warren, I think our sound is restored.
okay. Not looking at me, no, but okay, so sorry about that. Okay. So yeah, in terms of the Occupational Health and Safety Act, besides the employer providing a safe working environment that is without risk to health of employees, they also need to conduct a risk assessment.
Can we start? Okay.
From beginning. Okay. Okay, so sorry, let me start again. I'm going to be talking about the required precautionary measures, what is in terms of legislated in the Occupational Health and Safety Act and the regulations. Specifically, I'm from the Directorate of Occupational Health and Hygiene within the Department of Employment and Labour. Okay, so just the contents of the presentation. It's going to look at legislative requirements, specific regulations and the risk assessment, updating the risk assessment, what are the results of the risk assessment, legislated control measures, and then specifically control of exposure. And then we're going to look at the COVID-19 outbreak, and then employees' responsibilities and conclusion. Okay, so in terms of the requirements of the employer, in terms of the Occupational Health and Safety Act, Section 8(2)(d) of the Act requires the employer to conduct a risk assessment. It doesn't necessarily say the words risk assessment, but it says that the employer needs to identify hazards at the workplace. It needs to establish precautionary measures to protect, and then provide means to apply these precautionary measures. So that's just basically what a risk assessment is. That section of the Act is also validated by the General Safety Regulations, specifically Regulation 2, which supports that section of the Act. It also refers to a risk assessment for the workplace. Okay, then specific regulations and risk assessments. Okay, so there on your left-hand side, you've got the Occupational Health and Safety Act. Then those 6 regulations all specifically mention a risk assessment or an assessment of exposure, which must be conducted in the workplace, specific for that hazard. So the first one is Regulation for Hazardous Biological Agents, 6. Then you got Hazardous Chemical Substances Regulations, 5. Noise-induced hearing loss Regulation 6. Ergonomics Regulation 6, Lead Regulation 6, and Asbestos Regulation 7. Okay, so these 6 regulations, they require a specific risk assessment to be conducted by the employer at the workplace, particularly for biological hazards, noise, ergonomics, including physical, cognitive, and organizational, as well as chemical agents. Okay, so this clause that I've taken from regulations for biological hazardous regulations for biological agents, 6.3. It stipulates what must be included in the risk assessment that is conducted. Remember, all legislation is a minimum requirement, so if you do more than what is required, that is also allowed in terms of legislation. So in terms of conducting a risk assessment, specifically for HPA, let's look at the nature and the dose of the HPA to which the employee may expose to, as well as the suspected route of exposure. Also where the HPA might be present and what physical form. The nature of the work or the process and the reason for deterioration or failure in any control measures. What effects the HPA can have on the employee, as well as the period of exposure. Okay, so all the other regulations also have a similar requirement in terms of what to do in terms of their risk assessment for the specific hazard. Okay, so then the regulations also require that a risk assessment needs to be updated. It's still yellow. Okay, fine. Okay. Yeah, so you can't just do a risk assessment. It isn't just a once-off. It's a continuously evolving document. So yeah, it needs to be regularly looked at. So these conditions are when it is no longer valid, when control measures are no longer effective, when there's an update or advance in technological or scientific advances for controlling methods. There's also been a change in the work method, the type of work that's carried out, or the type of equipment used to control exposure. Also, if there's an incident or a occupational disease has been diagnosed, then a risk assessment needs to be re-looked at. Okay, so just further updating the risk assessments. So chances are that a lot of risk assessments out there at the workplace do not include COVID-19, or they don't include a HBA, which might not have thought to existed in the workplace. So that means that the current risk assessment is therefore no longer valid and needs to be updated. So as an employer and employees in the workplace, they should take this opportunity and not only look at hazards specific to COVID-19, but also other hazards which might have resulted from the outbreak. Some examples are there might be new chemicals that have introduced, particularly with cleaning and disinfecting of the workplace. Also, because of uncertain times, there could be additional stress, anxiety, and depression, which employees are experiencing. People are working longer hours, so they could be exposed to that. There might be additional manual handling and awkward postures where that wasn't necessarily required, and also the prolonged use of PPE. So all those can also be looked at when updating the current risk assessment, not only for COVID-19. Okay, so going on to the results of the risk assessment, these are the general results or control measures which come from conducting your risk assessment. So if we start at the top there, it looks at monitoring in the workplace. That's specifically to monitoring of hazards related to like airborne chemical agents, noise. You can also do monitoring in terms of hazardous biological agents, in terms of surface swabs. Then they'll look at specific control measures for a particular hazard. Also the introduction of programs to prevent injuries and diseases. There's also medical surveillance which should be conducted. Information and training that needs to be provided to employees and to visitors. Also work procedures as well as personal protective equipment. Okay, so in terms of what is legislated control measures, so in those 6 regulations I referred to earlier, the occupational health and hygiene regulations, they all follow a similar format in terms of the set out of the regulation. Okay, so they all have a section on information and training. Okay, so what that information training requires is the minimum contents of the training for employees and people that are visiting the workplace. So the training program must follow at least those requirements in terms of what is in the legislation. And also constant supervision needs to be provided at the workplace, not only by the employer, but as fellow employees and health and safety representatives and shop stewards. We all have a duty in terms of making sure that our fellow employees are working according to safe working procedures as well. Okay, then it also has the regulations have a regulation talking to duties of those exposed. Okay, this is not only for employees but also for visitors and contractors. They also have responsibilities. And this is in line with section 14 of the Occupational Health and Safety Act, which is responsibilities of employees at the workplace. Okay, then the regulations refer to, as said previously, conducting a risk assessment or an assessment of exposure. Then they also talk about monitoring. So monitoring is just a quantitative assessment to determine what the actual exposure levels are. Some of the regulations do require that hazards are monitored by an occupational hygiene approved inspection authority that is approved by the chief inspector as well. Then also they refer to medical surveillance. So the medical surveillance talks about your baseline tests and examinations, and then your periodic and your exit tests and examinations. And this medical surveillance should be risk-based, which means that whatever task you are performing, what hazards are associated with that, you should get the tests and examinations that are related to that hazard. So it doesn't mean that everyone who works at the workplace must go for all the tests. It must be specific to the task or the job which you're performing. And then just continuing, they also talk about record keeping. So it says what exact documents must be kept for records and for how long. So the records that need to be kept is the risk assessments, monitoring reports, medical surveillance documents, as well as training records. Okay, so in terms of the period, the risk assessment, monitoring reports, and medical surveillance should be kept for a minimum of 30 to 40 years, depending on which regulation they fall under. But the period for records of training must be kept for the duration of the employee's employment. Okay, then all the regulations also have a regulation that talks about control of exposure. I'll get onto that in more detail in the coming up slides, but that's mainly looking at the hierarchy of exposure. And then you go to personal protective equipment and facilities. So this refers to all personal protective equipment, not just respiratory protective equipment. And it also says that the PPE must be capable of preventing exposure. It must be correctly selected and fitted and properly used and stored. Information and training must be provided to those who are using the PPE, and it must be kept in good condition and efficient working order as well. Okay, then just the last couple of requirements. Also, if control measures are implemented in the workplace, it's not just also a once-off implementation, they need to be maintained and kept in good working order. So that's what the maintenance of control measures, equipment and facilities requires. Also, some of the tests and examinations in terms of engineering controls also need to be conducted by an approved occupational hygiene approved inspection authority. And then most of the regulations also, they have a regulation that talks about prohibitions. So those refer to, you cannot use compressed air for cleaning of a surface. That includes cleaning of individuals as well, cleaning their overalls or aprons or whatever clothes they are wearing. And also you may not eat, drink, smoke, or keep food or beverages in an area where there could be specifically chemicals or hazardous biological agents. There must be a separate place in the workplace for you to do those items. Okay, so just the control of exposure. Okay, so it's referring to the hierarchy of control. So I'm sure this has been covered previously in Mapume's slides. But yeah, it's legislated, so just to reiterate it, that we generally start with eliminating the hazard. If that's not possible, you can go into substituting the hazard for a less hazardous hazard. If that's also not possible, then you go into engineering controls, then administrative controls, and then lastly, personal protective equipment. Just a point to note that it's often a implementation of a combination of control measures. So it's not necessarily just a one control measure and then your hazard is gone. It might be a situation where you have to implement engineering controls, administrative controls, as well as provide personal protective equipment. You can see that is applicable in this COVID-19 outbreak, where an engineering control is introducing natural ventilation into the workplace. Administrative control is reducing the number of people that are allowed into the workplace. And then also PPE is providing masks for individuals at the workplace as well. Okay, so the regulations do require that specific control measures are implemented where reasonably practicable. So that means that if it's not able to do all of the control measures, an attempt must be made by the employer to implement some of them, at least by following the hierarchy of controls. So it starts off with limiting the quantity of the hazard, limiting the number of employees exposed to the hazard, limiting the time period of exposure, and then substituting for less hazardous hazard. There's also process separation, automation, and enclosure. Then you get local extraction ventilation as well as general ventilation. And then you get separation of different workplaces. Then there's also access control to prevent unauthorized access. And then you get developing of work procedures such as safe handling, use and disposal of items in the workplace. And then you also have maintenance, particularly for your control measures, and then as well as cleaning. Okay, so in April 2020, the Department of Labour did issue a direction notice for occupational safety measures in the workplace in terms of COVID-19. Just to point out for those of you that are in the healthcare sector, this is not applicable in the healthcare sector. There are other notices which have been issued by the Department of Health which are applicable. So those of you that are attending that aren't in the healthcare sector, then this would be applicable to your workplace. Okay, so in terms of what the notice is for, is it has given a guidance on to what health and safety measures can be implemented in the workplace, specifically for this COVID-19 outbreak. So some of the measures that it has introduced is administrative measures that would be limiting the number of people at work, getting people to work from home where possible. Also look at social distancing in the workplace. They refer to 1 to 2 to 1.5 meters. Symptom screening, issuing of sanitizers, and also disinfecting the workplace as well as other measures. It's also looking at the provision of cloth masks for employees, and then public access to the workplace, and then ventilation, and then other personal protective equipment. Okay, so then just finally before we conclude, okay, so employees in the workplace, they also have responsibilities in terms of Section 14 of the Occupational Health and Safety Act. So the responsibilities for employees are to take reasonable care of their own health and safety, as well as of others who may be affected by their acts or omissions. An employee also needs to cooperate with their employer to enable him or her to comply with the act. They also need to carry out any lawful order and obey the health and safety rules of that workplace. And also there's a responsibility to report any unsafe situation to the employer or the health and safety representative. Okay, then as mentioned previously, these duties are further supported in the regulations, the 6 regulations mentioned previously, and what the regulation specifically is. Okay, so just in conclusion, so yeah, the starting point is to update your risk assessment, not only for COVID-19, but for other hazards that might have appeared in the workplace during this specific time. Then the control measures which are identified by the risk assessment need to be implemented in order to reduce exposure, and they also need to be maintained as well. And then lastly, the effectiveness of how well these control measures work requires a collaboration between employers, unions, and employees. Okay, thank you.
Thank you for that. That was the case speaker from the Department of Employment and Labour, Warren Mullen, very effectively dealing with the issue of the required precautionary measures required. Our next, I'm just adjusting our camera. We need a bit of a technical correction earlier. There we go. Okay, so what is critical is for you as shop stewards and workplace representatives to know what needs to be done in order to ensure what the correct precaution measures are in place. The next speaker dealing with screening procedures and follow-up, that is when workers get back to the workplace, is Dr. Odette Volnick from the NIOH's Occupational Medicine section. Welcome, Odette.
Thank you so much. Thank you, and thank you for having me today. I'm grateful for this opportunity to be able to speak with shop stewards around the preventative measures that are in place in workplaces or should be put in place in workplaces, because shop stewards play a vital role in ensuring that these are done. So with regards to, I know my colleague for me also dealt with this slide, in terms of potential sources of this virus, the coronavirus, getting into the workplaces. We know, if you see on the corner with the door, that people would come and be infected in the communities, and infected workers will be able to come into our workplace and infect other people in the workplace. Or sometimes, as part of our jobs, particularly in healthcare, but many other settings, during our actual work that we are performing, we can be exposed to a risk in the workplace. And this and spread in the workplace equals spread in the community, and we can't have this. So I know Mpumi spoke to this a little bit earlier. There are many occupations that are at risk. Outside of healthcare, there are lab workers, airline operators, retail workers who deal with the public, waste and water management workers, environmental health workers, even people who come into homes to repair things could be at risk, and even maybe even in a financial setting when they have high risk of traveling to places that may have community spread of COVID-19. But now with the ban, this is not such a problem. So firstly, what is medical screening? Medical screening is basically designed to detect early signs of any illness by doing some kind of test to an apparently healthy person. And these tests can, depending on what we test and what we're screening for, these can be questionnaires, they can be physical examinations on people, or they could be sort of investigations, blood tests, different other kinds of tests. So oftentimes within occupational health, it is often a secondary prevention strategy where we want to detect early whether there is an effect of a hazard within a workplace. But in the time of COVID, it also is used to prevent infected cases getting into the workplace. So it can also be a primary prevention strategy. And within where there are occupationally acquired disease, it's also used often as a way to screen to see whether the mitigation factors or the controls that you put in place in the workplace are actually effective. So I know Warren spoke to the responsibilities of the employer under the Occupational Health and Safety Act. And under this act, we also have a directive with regards to measures that can be put into the workplace in this time of COVID-19 to try to protect employees from infection. And it also, this document talks to symptom screening. And it states that every employer must take measures to screen any worker at the time that they report to work to ascertain if they have any observable symptoms associated with COVID-19. And it also requires every worker to report when they're suffering from any of either the common symptoms or even the additional symptoms like body aches, loss of smell, loss of taste, nausea, vomiting, diarrhea, fatigue, weakness or tiredness, to report this to the employer. And it requires workers basically, if even during their shift, they experience any of the symptoms that are associated with a COVID-19 infection, that they need to immediately report to the employer. so that ongoing spread doesn't occur in the workplace. So in terms of, how employees can be monitored with regards to COVID-19, there can be, employers will use different strategies depending on what is appropriate, what resources they have, and what's appropriate to their workplace. So some mechanisms of medical monitoring can be self-monitoring, where the employees monitor themselves by either taking their fever twice a day or checking for symptoms of COVID-19. But when this strategy is employed within the workplace, there needs to be a plan on who should the employee report to should they develop any symptoms. Another strategy that can be employed is active monitoring for the symptoms. And when employing this strategy, there needs to be regular communication with the potentially exposed employee to basically assess for the symptoms, to look for fever, to look for are employees having any symptoms of COVID. And this is usually used in high exposure settings. So when exposure in the workplace is a high risk, it's usually the one to use. Communication in this strategy needs to be done at least once a day between the occupational health team or the infection control program and the employee in this high-risk setting. So when we're screening and doing medical screening, there are many tools that can be used. Often the commonest one to use is a symptom questionnaire. And people use this in different ways. It can either be a paper-based questionnaire asking about the specific symptoms and whether the employee has any of the symptoms. Some people are using it on an app. Some people are using it when they go into work, they log in and they tick certain boxes whether or not they have symptoms on a computer screen. But basically, the commonest screening tool is to use a symptom screening questionnaire, but can be administered in many different ways. Oftentimes, people are also doing temperature screening. And it's important to note that temperature screening shouldn't be done alone when looking for COVID or when screening for COVID-19, because it may not be present in people who are either the elderly or immunosuppressed, or if people are taking medications like ibuprofen, where this is lowering their temperature. So it's actually important to do temperature screening. It can form part of a screening process, but ideally symptom screening should always be there as well. So in terms of screening in the workplace, the recommended procedure is firstly always, my colleagues Mpumi and Warren both spoke to the fact that a risk assessment needs to be done to determine the COVID-19 risk to the employees in the workplace. And ideally, once this is determined, this then allows you to have your appropriate intervention or control at the appropriate part. So in terms of at the start of every shift, ideally workers should be screened for symptoms associated with COVID-19. And should an employee report any of these symptoms, if they report before they come to work, they should ideally report that they have got symptoms but not come to work. But they need to report this to their appropriate line manager. If they present with symptoms and when they are screened while they're at work, and it is found that they do have some symptoms, they need to be isolated immediately. Ideally, they should be provided with a surgical mask, and they should be transported to a place where they can be assessed further. This has been written up according to the directive from the Department for Employment and Labour. Once the employee has been dealt with in the workplace, it's important to assess the risk of transmission and sort of disinfect the area where the worker made contact. And then it's important also to follow up on the results of the worker. And based on the results, there may be steps that need to be followed. If a person is found to be positive, COVID positive, it's important that the workplace knows, ideally the medical staff within the workplace, because there are issues of confidentiality that need to be sorted out. But you know, if there's an occupational medicine team, occupational health sister within the workplace, this information, they need to have follow up on these cases. And oftentimes, these cases have already been notified according to the doctor who diagnoses and who checks the test results afterwards. They would need to notify to the Department of Health because COVID-19 is a notifiable disease. But within the workplace, a workplace investigation needs to occur when someone is found to be infected with COVID-19 in the workplace. So an investigation needs to occur so that the contacts of that person, if there are any close contacts that the infected person was in contact with in the workplace, the contact tracing needs to be done, and these employees monitored even closer for infection. Also, it's important, particularly in this time, COVID-19 is giving many people a lot of anxiety, a lot of stress. People worry about being infected and further infecting their families. So it's also important to look at ways of how to psychologically support the infected worker in the workplace. And if the infection occurs after the workplace investigation has been done, you find that the infection occurs is occupationally acquired, this needs to be reported to the Compensation Commissioner as well as the Inspectorate Department at the Department of Employment and Labour. So just to reiterate, you know, as infections are growing within our country, you know, we are going to get people who have COVID-19 coming into our workplace. And just to reiterate, the procedure that needs to be done is that once a worker is confirmed, we need to ensure that the reporting is done. The employee needs to be isolated. At the workplace, a workplace investigation needs to be done. Contact tracing needs to be done, and cleaning of the appropriate spaces. So once the workplace investigation is done, it would be able to inform the workplace of who were the contacts, as well as what areas did that person have access to, or where were they around, so that appropriate cleaning can occur in that place. Now, when do people come back into the workplaces? Oftentimes on recovery. So this, ideally, the person is isolated and out of the workplace until they are better. And in mild cases, oftentimes 14 days after the symptoms onset, or in severe cases, this could be longer than 14 days. But ideally at, you know, as defined by the medical treating the practitioner, these people on recovery can then be reintroduced into the workplace. So we've seen this slide before, but it's just to also reiterate that there can be risk, just that middle circle. There can be workplace or occupationally acquired infection. And this risk could either be high risk or low risk. So I wanted to bring through this treatment or this workplace management algorithm. When people are exposed to a high level of exposure in the workplace. So when somebody, let's take, now what is a high risk exposure in the workplace? Firstly, they're very close contact with this confirmed positive person in the workplace. That means within a meter, they are in contact with this person, and it's for a prolonged period for about more than 15 minutes. Neither people were wearing PPE, or there was a failure of PPE where PPE was worn. There was either a breakage to this PPE in terms specifically respiratory PPE, or there was direct contact with somebody's respiratory secretions of a known positive person. So that is a high risk exposure in the workplace. So this is a healthy worker, it's in the workplace, but then they come in, they have a high risk exposure. And what does a workplace then do in these cases? Now, with regards to essential workers basically, you know, both processes follow a very similar pattern for essential and non-essential workers, but we've broken it down to essential workers. And probably in this category of people, you know, the healthcare workers, this category of people would most likely be exposed or could be exposed to a high risk. It's important to say that if you look at what is a high risk exposure, close contacts, people within 1 meter, if you don't wear PPE, these are things within our workplaces. If we have these controls in place within workplaces where we are able to, you know, have social distancing, where we are able to each person wear masks in the workplace, we are able to have the necessary precautions and controls in place. Oftentimes we won't have such a high risk of exposure. But if this does happen, what needs to be done is firstly a workplace investigation needs to be done, and the exposure is assessed. So was it a high level of exposure? And this should be confirmed by the line manager, and then cleaning needs to be initiated. And this should ideally be reported to the NICD because these people would be a close contact of that COVID-19 positive person. These people with a high exposure need to self-quarantine at home. So they need to go from the workplace because they potentially could have symptoms. And they be quarantined, ideally for 14 days, but there are some issues that may develop with staff shortages. And so for essential workers, the guideline from the Department of Health is that self-quarantine needs to happen for a minimum of 7 days, with daily, during this time, this person is screened daily for symptoms. And if it's an essential worker and they don't have symptoms after 7 days of being screened, being in their home, screened for symptoms, there is a proviso that essential workers may return if after 7 days they've been screened and negative, or screened for symptoms and never had symptoms, they can have testing, and if the test is found to be negative, these people are then kind of safe to go back into the workplace and can return to work. With regards to non-essential workers, and the essential workers has been defined according to the Disaster Management Act. But sort of non-essential workers, basically the same procedure occurs. There has to be a workplace investigation done to decide, is this a high risk of exposure? And this should be confirmed by the line manager. And then cleaning needs to be initiated. This needs to be reported to NICD because this would be a contact of the COVID-19 confirmed case. And then self-quarantine for these employees is essential for a minimum of 14 days. So there, I forgot to mention when we were talking about essential workers, that mental health support is quite necessary. And we need to be thinking about how to put these support structures in our workplace. And return to work for non-essential workers needs to be, my colleague Dr. Mpumi spoke about, the transmission period being up to 14 days. So return to work once people have been at home, monitored for symptoms. If there's no symptoms developed on day 15, they have no symptoms, they can come back into the workplace. While workers are in self-quarantine, they will be monitored for symptoms. Should symptoms develop, they need to be referred appropriately, quickly, and go on for testing. So workers who are exposed to low risk in the workplace. We spoke about the high risk employees. Now, a low risk, I'm sorry, it's a really small little star there, is people who are exposed to a positive contact, but their exposure was from more than 1 meter away, and for a time less than 15 minutes. Or if they were within 1 meter of the positive person, if they were wearing appropriate PPE, this is a low risk exposure. Also, if the infected person had a surgical mask on, so basically they were keeping their secretions were kind of being contained, this is also a low risk exposure within the workplace. And when this happens, basically, if there is an exposure, you need to decide, an investigation done to decide, is it high risk exposure, is it low risk exposure? This then needs to be confirmed by the line manager. And if it's a low risk exposure, the employee can continue to work but should self-monitor for any kind of symptoms for COVID-19. And the self-monitoring needs to be done for at least 14 days because of that incubation period. If at any time someone is symptomatic, they need to be immediately removed from the workplace and be referred for testing. Okay. So now we spoke about when there is infection within the workplace or even risk within the workplace. But now when does an infected person get back into the workplace? There are two types of strategies that have been mentioned by the CDC. The first one is a test-based strategy, which basically says that it is safe for an employee to come back into the workplace when there's been their symptoms, their fever, as well as their respiratory symptoms have improved, so they're no longer symptomatic, but also they have a negative result from 2 consecutive swab specimens collected more than 24 hours apart. However, within our climate, within the fact that we don't have, testing is limited, a non-test-based strategy can be used. And the guidance from the CDC says that people can return to work when at least 3 days have passed since they have recovered, where there's full resolution of their fever without the use of fever-reducing medication, and there's no respiratory symptoms, And also, so there's 3 days of their symptom stopping, but also there needs to be at least 10 days have passed since they first had the symptoms. Okay. And on return to work, it's important that all employees after isolation, after quarantine, should have some general work restrictions. And these include that ideally there should be a medical evaluation to confirm that they are fit to come into the workplace. They also should continue wearing surgical masks at all times while at work for a period of at least 21 days from the initial test. They need to continue with all the basic prevention procedures like social distancing, adherence to hand hygiene, respiratory hygiene, and cough etiquette. They also need to continue to self-monitor for symptoms even after recovery. And if there's any if they do present with symptoms, if their symptoms recur or even get worse, they need to report immediately to their medical practitioner. In the case of healthcare workers, it's important for the healthcare workers to possibly, after they've come back, to avoid contact with severely immunocompromised patients for the short term. So it's important that workplaces have certain protocols in place, that they know in the event of a symptomatic person, where this person can be referred to testing and for treatment. We need to have protocols on isolation and on contact tracing. And within the workplace, in the event of a positive person in the organization, we need to know exactly what are the steps to follow. There needs to also be a protocol on return to work of this infected person, as well as the restrictions that need to be placed on this person after they have recovered, but on entering the workplace. And we also need to have protocols about social distancing, hygiene, infection control. So we basically need to minimize the risk of transmission in our workplace. And this can't be said again. It's important that our members are communicated with, that their awareness to what the symptoms are, how it is spread, what controls are in place in the workplace. Like my colleagues have stressed, it's important that employers and organizations review their health risk assessments and look at the hierarchy of controls. There has been given our restrictions with regard to testing in the country, no mass testing should be done, but people should be screened for symptoms. Should people be symptomatic, they should then go on to be tested. We need to minimize risks in the workplace, and it can't be said enough. We need to have social distancing in the workplace. We need to promote regular, thorough hand washing by our employees, by contractors, by customers, by visitors, by our patients who come into the hospitals. We need to teach people, all the people who would come into our places of work, respiratory hygiene. And we need to avoid touching our face, especially while we're at work. Our members need to be advised on self-assessment, the importance of reporting symptoms quickly, and what appropriate sick leave policies are in place within our organizations. And screening and identification of potentially infected employees needs to be done so that these employees can limit contact and movement and spread within the workplace. We need to encourage and insist upon that where people are symptomatic, they need to self-isolate and stay away from the workplace. And it is ideal to have occupational health input into the program that you have in your workplace so that it is managed appropriately. Thank you for your time and your patience. I know my colleagues have spoken to this slide already, but these are the services that we offer. if there's any occupational health queries around COVID-19, please feel free to either call the hotline or send an email, and where we can, we will give you feedback as soon as we can.
So thank you very much for that. That's Dr. Odette Volney, another member of our occupational medicine section. So Odette, we're going to prepare now for the Q&A. I'm just going to move your chair slightly back so that we have our required distance between each other. For those who are watching us, your camera does create a bit of a distortion, but we've ensured that our distancing here is according to what is required. And because we're more than 1 or 2 people in the same room, we have ensured that our colleagues do hand sanitize, that all of us wear masks. Somebody commented in the chat box, why are we wearing masks? It's because of the required social distancing and containment measures that we've got to keep in mind. And therefore, okay, there we go. I'm just going to do some slight adjustments. Oops, that's towards Warren. Okay, there we go. So we have about 15 to 16 minutes for Q&A, and we're going to ask our colleague just to place some of the questions for us on the screen. Also, thank you to my colleagues, Dr. Tanisha Singh, as well as I think and Warren, for answering some of the questions live. For some of you who've placed your questions in the Q&A box at the bottom of the screen, some of those questions have already been answered as the presentations were going. So maybe I should start with a question. Oh, there we go. So the first question with regard to the invite for Friday, I've answered that in the box. The question we'll deal with now is there evidence of nosocomial infection? You can see it, occupational medicine colleagues is ready to answer. So is there evidence of nosocomial infection, not on healthcare workers per se, but evidence of patients who acquired COVID-19 at the health facility, who didn't have it on admission and was not in the incubation period? Over to you.
There has been evidence of nosocomial infection within hospitals, and that talks to infection prevention procedures to be effective and in place, not only for the worker but also for the patients in the beds next door.
Okay, well, thanks for that. So here's a question about how long the virus lasts on surfaces that are painted, like walls, tables, which is painted.
I don't think we have that information, but mostly what we have is mostly on surfaces that that are sort of bare, as we said. But then the beauty with painted surfaces is that usually they're easy to clean, and in terms of as you paint, you're sort of covering the actual material underneath. So it should be almost like the plastic, how long it should last on plastic, depending on the nature of the paint, is it water paint or oil paint and so forth. But because the paint becomes the cover, it's sort of, it should be almost like plastic, but I don't think there's any specific study that has been done or evidence that's specific to that.
I think the important point that is being emphasized is that your precautionary measures, your containment measures are critical. We can't, we should be concerned if those workspaces have not been cleaned, as Warren indicated earlier as well, in terms of your risk assessment. If your risk assessment indicates that the surfaces in the workplace, and including walls and windows for that matter, and high-touch surfaces needs to be cleaned regularly, let's not consider how long or the length that the virus might still be active and problematic. The next question is, hospitals are still insisting on staff displaying symptoms to report for work, especially when staff had been in contact with positive cases. This is happening at the Uitenhage Provincial Hospital at present. Is there any way someone can intervene patients in hospitals' immune systems are already compromised. But perhaps, Warren, is that sort of a monitoring and enforcement consideration?
Yeah, I think I did respond to this one online. I think I said to the person that they are welcome to report to their closest Labour department, Bloomington Labour department.
Okay. So do make sure that you have the contact details, names and so on of the Department of Labour enforcement, is that inspection enforcement services inspectors, and especially those who might be allocated for your district, region or workplaces. And please report that, but most importantly, please ensure that you engage with your health and safety representatives at your workplace, and as shop stewards follow the mechanisms to get solutions in place. And this must be based on the most recent and up-to-date risk assessment and the different functions and roles allocated. The next question is, the Department of Health in the Western Cape is giving out replacement masks for N95 masks. That is the 8810 SSA for dust and mist masks. That is South African Bureau Standards approved, SABS approved. But my question is is it NIOH approved to use in the place of the N95? Our members were trained to use the N95 when dealing with the COVID-19 positive cases. So what's the approach to replacement alternative masks that people are not sure if it is meeting the local standards? Could you just, otherwise, yes, thanks.
Okay, so also the N95 is just a term used by for that specific manufacturer. So, and a lot of the legislation that has been published recently, it's also a minimum. So if there is a similar or better mask that is issued by the employer, that is also fine. I'm not too familiar with that specific one that person is mentioning there, but if it is exactly the same as the N95, then it shouldn't be a problem. The employer would then just have to provide their employees with information and training, because if they've given information on the N95 and now they're issuing a different PPE, they will then just have to provide them further information on. If it's the same, maybe you have to use it differently. All those requirements in terms of providing information.
Aditi, would you add something?
No,
Okay.
I'm going to say I don't know that specific mask.
Yes, okay. So if you've had a response, but for that particular mask, the 8810 SSA, if you feel you want to get some more specific details, please email us at info@nioh.ac.za, info@nioh.ac.za, and colleagues in the occupational hygiene, as probably also in the immunology sections, can perhaps give you a little bit more detailed response. But it's important. Warren has indicated you must engage with your employer and the health and safety reps to get a sense what is the comparison between the standard, branded N95 type mask and that particular mask, to have a clear comparison. Is it also having the same level of protection against very minute particles like this particular coronavirus? The next question, is there a difference in risk between those on ARVs and retrovirals and those who are not?
Yes, there is a difference. First of all, if you are in ARVs, the assumption is that you've been infected with the HIV virus. But if you are not on ARVs, it could be because you have no disease, or you have disease but you are not really controlled because you are not on ARVs, or maybe the disease that doesn't require. So yes, it's quite a broad spectrum of possibilities. But then what is best is that anyone, if maybe somebody has HIV but is not on ARV, that is actually a clinical decision. So the best person who can comment there would be the attending doctor. Maybe the person is not really at a stage where they should be on ARVs, or the person has not started ARVs maybe because they have not consulted, and then it would mean different things. So it could mean you had an AD disease that hasn't been doesn't require ARVs as yet, or they're still being worked up on something else, or it could be severe disease that might have required ARVs, but you probably not on treatment or you've defaulted for some reason. I'm not sure what exactly they are referring to.
I think a critical take-home point for you as a employee representative, as an official office bearer or a workplace representative belonging to the union, is you need to ensure that you have your members' informed consent in order for you to consult with that member or that member's medical doctor that deals with these aspects, in order to determine if that is a critical factor for the protection of that worker within the workplace. So it's important that you get the specifics, and so the doctor may, with your proving informed consent and with your member, be able to provide you with a medical report, and that report must be treated with the same confidentiality in the workplace and probably be shared with the employer's occupational medical practitioner. The next question is people with comorbidities, that's people at high risk. There seems to be a common misconception among supervisors and managers that these are only people above 60 years with comorbidities such as heart disease, hypertension, high blood pressure, I guess, cholesterol, diabetes, etc. My understanding is that there are people that are 60 and older with and without comorbidities, and younger people with comorbidities. In doing the risk assessment, please clarify who should return to normal work and who should not return to normal work due to the consideration of comorbidities.
So what would normally happen is that you've got a group of employees, like you indicate. So each person, or maybe of the 10 people, you can find that they're all at risk. But now the issue is you try and categorize risk. Is it extremely high risk? Is it high? Is it moderate risk? Is it low risk? So that's the first thing that you look at. So I'll take the example that you provided. Somebody could be 60 with no comorbidities, but age on its own is a significant risk factor. But then now if somebody is 60 as well with a number of comorbidities, so that one in terms of the severity of the risk, then that one will be above the one who's 60 with no comorbidities. But it doesn't mean that the one who's 60 is not at risk, because it is a risk factor that we know that, in terms of their immune, the stability of their immune system, they are likely to have worse off disease. But then if you come to another category where somebody is, let's say, between 40 and 60, but they also have comorbidities, they are also at risk, but you'll find that it's high or rather moderate risk, not compared to the other one. So what the take-home message is, every person should ideally have their risk assessed and reviewed, because it's very difficult to compare. There might be a younger somebody who's a chronic asthmatic who's known, or there might be less than 60, but because the asthma is not well controlled, then you find that the person ends up in a higher risk category than somebody else. So yes, it's true, it shouldn't only be focusing on 60 years and above, but 60 is a known, issue that needs to be considered.
Okay. Yes, Warren?
Maybe add there that also you find that employees that don't want to declare to their employers what comorbidities they have. So now is a situation where employees need to go to their employers and declare what comorbidities they might have, so that the employer can make an informed decision with regards to assessing the risk of that individual. It still needs to be kept confidential. But the employer needs to know as much information as possible so that they can do a proper risk assessment and put in effective controls, which is going to, in the end, help that person in the long run.
Yes.
So I'd also like to add something to that. I think it's also important that employees with comorbid conditions seek medical attention, because it's not the comorbid condition itself that's caused that makes them at risk. Warren and I can both have diabetes, but it is the control of it. If my diabetes kind of puts me in the hospital constantly and it's not able to control them on my maximum treatment that I can have, but I'm still not controlled. And Warren, on the other hand, is taking his one tablet every day and his sugar levels are perfect. It's not the condition itself, it's the control of the condition, because it's how the condition affects the person's immune system. Is this condition that they're having kind of suppressing their immune system? So I think the treating doctor is also very important to have on board, to kind of say where they are in terms of the severity of their condition, the control of the condition, and to be able to communicate this to ideally, you know, the medical professional staff within the company. But it requires, it's not condition specific, it's very much an individual assessment of that person's, how it's affecting that individual employee.
Can I also add that while Dr. Odette has indicated that people need to get to their own doctors to be assessed and so forth, you know, for organized labor, I think maybe I'll have to use this opportunity to say, this is the time where the role of an occupational medical practitioner is very crucial. Because if you think of it, people might be, you know, we are in the health setting, but you might feel that how safe am I if I disclose that I've got something, let's say hypertension, to my employer? The best that the employer can do for the employees is to have a doctor who will understand what your doctor has said coming from outside, but translate that into the workplace. Because remember, your doctor will tell us about your asthma, and we say your asthma is controlled and this and that. But it's not easy for your doctor to say you can work in CSSD, or you can clean in pharmacy, or you can clean wherever. It is the doctor in the workplace who knows that, but our CSSD is very busy. Our CSSD has a lot of public interaction and so forth. So that is the role of the doctor who's in the workplace, or an occupational health practitioner in the workplace, because over and above their understanding of the medical condition, but they also know the workplace, because hospitals are different. It's very not easy to say this hospital's pharmacy is the same as another hospital's pharmacy. That is the facility-specific medical practitioner or health practitioner who can provide on that. So even though we are also health practitioners, we are, you know, we are shop stewards. Remember, there are also matrons who are also, you know, have understanding of health, you know, conditions. But then in their line, they are line managers. So you just need somebody who's neutral, who's not a line manager, to look into the medical condition, more like a mini risk assessment.
Well, we've reached the sort of almost closure of our session today. So we won't be able to cover all of your questions that you've shared with us, and we will ask the presenters to look at the questions and share some of the answers with you, keeping in mind that we have another session happening on Friday. So maybe a last round of comments from my colleagues as presenters, and perhaps I should start with Warren. Critical comments you think for our audience as employer representatives in workplaces that should be COVID-19 prepared and have prevention in place?
I think the main aspect from our side is they need to cooperate with employers. We don't want a fighting situation between parties. We want everyone working together to make the workplace as ready as possible, as controlled as possible, so that we don't get occupational diseases in the workplace.
Odette?
I think that shop stewards have such an important role to play here. I think that this whole situation that we're in creates so much anxiety for workplaces, and workers need to be informed. You know, without the information, they're scared. You know, and that causes them to react in certain ways and to not want to come to work, to not want to engage. But I think, you know, it's so important for awareness and for the controls that need to be in place for the disease itself, how it's spread, how the workers can protect themselves. And I think that, you know, our shop stewards help us with that.
For me?
For myself, I'd like to say shop stewards play a big role We've had similar trainings where we said employers must do this and HR must do that. And I must say that COVID has given us such a sense of rush. So I would really encourage our shop stewards that whatever happens in the workplace, don't wait for the employer to do something and come and oppose. This is the time that we can, for our members, show the presence, actually show up and say, can you help with the risk assessment? Can I be involved in the team that does the risk assessment from this place? Because areas that are problematic where they are concerned. Rather be involved in the risk assessment and have your say there that these are the issues and so forth. Because the employers can do with every resource at this time.
Well, clearly the Labour Relations Act spells out the roles and functions of the trade union representative. And I think you need to be guided by the Labour Relations Act with regard to your roles as shop stewards, office bearers, as well as the officials of trade unions. In addition to that, you have another group of colleagues you must work with, and that is the health and safety representatives who are guided by specific provisions in the Occupational Health and Safety Act. And your dialogue with your employer is critical to ensure that your workplaces are not going to be sites of super spreading of the COVID-19 disease or the particular coronavirus as the hazard. Our lockdown levels are being changed, and therefore the role you're going to play in the workplaces where you represent the interests of your members is going to be critical. The coronavirus is not going to distinguish on the basis of union membership or, in fact, role or status of people in the workplace. And therefore, this is the one element of a hazard that's going to require us to form the strongest basis of solidarity to deal with that. And that will require sometimes some difficult discussions with the other stakeholders and role players, both in your industry and in your workplace. But all those protocols and all those standard operating procedures must be adjusted on the basis of the standard operating procedure to ensure also that your members' medical confidentiality is respected by yourself, your organization, and all other parties within the workplace. And on that point, I need to say thank you to our presenters. Our session was opened by the head of our COVID-19 outbreak response team, Dr. Tanusha Singh, who's also heading our immunology and microbiology section at the National Institute for Occupational Health. We also had the very valuable contributions by Warren Mallon, my apologies, I almost called you by your surname first, who is a highly qualified occupational hygienist, I think with a master's in public health, if I got that right, who's contributed to the COVID-19 precautionary measures. And my two colleagues from the occupational medical section, Dr. Odette Volming and Dr. Mpume Ndaba, who dealt with workplace preparedness and screening procedures follow. As a reminder, this video recording and audio recording will be uploaded on our now zero-rated website, zero-rated by all the main cell phone companies. Please go to our website, www.nioh.ac.za, and you'll find the recordings of the previous sessions there, including the presentations that you've seen today on this particular webinar. You will find that also on our website. We do also send it to your email addresses. For our session on Friday, please remind your colleagues in your workplaces, your fellow shop stewards, and the other union representatives to join us, and you will receive the invitation via email for the link to register for that Zoom session. I want to say thank you very much for joining us here today. And from the NIOH, our partner, the Wits Health Consortium, and our supporter and funder, the Health and HWSETA, we say thank you very much and see you on our session on Friday. Goodbye.